Sweet lemons.
Thank you for coming on. I don't even think I properly said that when you first turned up before we switched on the cameras. So thank you for coming on. Before we switched on the cameras, you're telling me a bit about what you do and everything. But for the people who might not know who you are, do you mind just giving them a background?
Yeah, of course. So I'm Simon Erridge. My background is as a medical doctor. Graduated just over 5 years ago now. And pretty much from within 6 months of graduating as a junior doctor, I started a role around researching medical cannabis at Imperial College London, and very quickly that evolved into a role at Sapphire Clinics, which is now Curaleaf Clinic, looking at how medical cannabis is affecting people in their day-to-day lives.
So just like going back to the beginning for you, how did you get interested in this like area of research?
Yeah, it all started out of a collaboration with one of my supervisors at Imperial College London, with a guy called Dr. Michael Sodergren, and he set up the medical cannabis research group at Imperial to look at the effects of medical cannabis across three broad themes: pain, cancer, and inflammation. And we were originally looking to set up.
Can I just put that like closer to your face?
Yeah.
Okay, sorry, there you go.
So we were originally looking to set up a research study around looking at the acute effects of medical cannabis for patients that he sees on the NHS. So he's a liver and pancreas cancer surgeon. So when he does an operation, he does big cuts, people left in lots of pain, and we know that lots of people are left on opioids chronically after they leave the hospital. So he was always looking for ways in which he could circumvent that and reduce the amount of opioids that he's prescribing for patients when they go home from hospital. During the process of that, when the law changed in November 2018 to make medical cannabis available to be prescribed, what became really clear and evident was that although from a legal point of view, the restrictions had changed around prescribing medical cannabis, but I mean, you're a doctor yourself. You know that you're not prescribing medical cannabis in ED or in clinic or on the ward. And that's pretty much, so there've only been 5 prescriptions for unlicensed medical cannabis products across the UK. The majority for them for children with refractory epilepsy.
Okay.
And so that's how I became involved sort of in helping to set up a clinic to help sort of service the needs of people who wanted to access medical cannabis but had nowhere to turn to. In 2019, there was data to suggest that 1.4 million people were accessing illicit cannabis in order to be able to self-treat, their health conditions.
Wow.
And so that's kind of how I became involved in more of the sort of clinic aspect of things, was to kind of provide a route and avenue for those patients who are kind of left unserved by what's available to them on the NHS because of, well, there's many barriers that we can go into.
Yeah, of course. So, because I know, because in America, like when it was made legalized in like California medically and all that, it seemed like it was almost quite easy for people to get, like, oh, I have a headache, prescribe me some cannabis. But here, what are the actual like avenues someone has to go through to be like, I want to get medical cannabis, or is that even how it works? Does it have to be a doctor who suggests it first?
Yeah, there are a lot more barriers to accessing medical cannabis here in the UK, and that has good and bad consequences. The good thing is it is a really rigorous, clinically robust process that is overseen by doctors at a consultant level throughout. So to be able to access medical cannabis, it's almost like any other unlicensed medicine with a few extra sort of bolts and braces on top of that. So you need to demonstrate that you have a condition for the first instance. So let's say chronic pain, which is the most common condition where medical cannabis is prescribed in the UK. You need to demonstrate that you have that condition to start off with. Then you have to be able to demonstrate that you have tried a sufficient number of licensed therapies for chronic pain. And so that may differ on the type of condition, because all the different treatments kind of for whether you have arthritis, back pain, neuropathic pain, fibromyalgia, etc., may be slightly different, but you need to be able to demonstrate you've tried a sufficient number of licensed therapies. Then if you have done that and you go to a consultation at somewhere like Curaleaf Clinic and you have to be seen by a consultant in the specialty, so you have to see a pain specialist. There are 550 pain specialists in the UK. That sounds like a lot, but it's not really that many.
And are they anaesthetists?
yeah, there'll be anaesthetist by background who then.
Really quick, before you guys click away, I just wanted to take this opportunity to say thank you so much for watching. You guys watching this channel means the world to me. My analytics show that 80% of the people who watch and enjoy this channel are not subscribed. So if you have a chance, please smoke that subscribe button, smoke that like button, because honestly, I just want to bring more people to you guys. And I want to make it so that this channel has 1,000 subscribers so we can actually make this something that can continue. I can do the watch time, but I just need the subscribers to get to the monetization holy land. So if you guys have a chance, smoke that like button, smoke that subscribe button. But back to the show. Bye bye.
Sort of subspecialized. So even though anesthetics is the largest hospital specialty, not many of those then go on to be sort of outpatient chronic pain specialists. So so you have to see someone who is a chronic pain specialist, and then they have to discuss their care with a multidisciplinary team of other consultants.
Okay.
So at Curative Clinic, for example, we have pain specialists, psychiatrists, sort of general medics. They typically are more gastro-focused, so see people with Crohn's and ulcerative colitis, and neurologists. And that's the kind of general makeup of the MDT plus some pharmacists. So they have to then go through that process to decide, are they eligible? Are they suitable? If so, what is the right formulation for them?
Yeah.
It then has to be written on an FP10 pad. So,
oh my gosh.
So this is I don't know what you use in your NHS. Like, what I imagine you use electronic health records.
Yeah,
and so
of course, yeah.
when you do a prescription, all online.
Yeah.
Blah, 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 not even like old school pen and paper, just sign
Yeah.
and rewriting all that kind of stuff. So this is like old school pen and paper, has to be signed, and then it has to be sent to a specials pharmacy.
Okay.
So it can't go to Boots, it can't go to any other sort of high street thing. So it has to go to a specialist manufacturer of unlicensed medical cannabis products. So there's only a handful of those across the UK. So you've got to courier it there.
Yeah.
And then only then can it be sent to the patient. So there's a lot of rigor to it.
Yeah.
But that also creates a number of barriers. And obviously, probably one of the key barriers is that this is all in the private sector. This is not happening in NHS. So
of course.
So like finances, and in the UK we're very used to a public healthcare system whereby everything is free at the point of access. And so, even some people who have the financial means that, they're maybe a bit reluctant to even go down that because they think, oh, well, I normally get my healthcare for free. And rightly so. But, and then, you've got to think about all those societal barriers that also come alongside that, whether that be what are my friends and family going to think, what's going to happen if at work, going on holiday, all those kind of things come into play as well.
Of course. So it's like, so for where it is now legally, so licensed versus unlicensed. Can you just explain the difference to that, if you can speak to that at all?
Yeah, so there are 3 licensed medical cannabis products. Some people are probably most familiar with Sativex, like the generic name is nabiximols, and that is licensed for multiple sclerosis associated spasticity. So that is available on the NHS, but only for that specific indication. Again, that's only something that can be controlled at a consultant neurologist level. It won't be. So when we talk about licensed medicines, those are ones that have gone through a process with the MHRA, essentially to demonstrate that they have the efficacy and safety for that specific population. So Sativex has done that for that population. Other licensed medicines include Epidiolex, which is just contains CBD. There's no THC in that. And sorry, I should probably explain that a bit better. CBD, cannabidiol, which is non-intoxicating. It won't produce a high no matter how much you take of it. Whereas THC would be, it can cause a high at sufficient doses. That's what recreational users of cannabis are using cannabis for. But with medical cannabis, you want to ideally start at a low dose so that they don't experience that. And as you titrate it up, there's actually tolerance to that effect. So you can gain greater and greater sort of clinical effects without having that high. So, but then to come back to what I was really saying about licensed product. So Epidiolex is licensed for treatment-resistant epilepsy in a couple of rare disorders, so Dravet and Lennox-Gastaut syndromes. And then finally Nabilone, which is a synthetic version of the tetrahydrocannabinol THC. And that's licensed for chemotherapy-induced nausea and vomiting. So that's kind of all on one end of the spectrum, and they are all, so Sativex is a spray. Epidiolex is dropped under the tongue. But then unlicensed medical cannabis products is like a huge, broad array of different things.
Yeah.
So that the most two common are oils, again, which are put under the tongue. But alongside that is dried flower.
Yeah.
So flower from the plant that's manufactured to a pharmaceutical standard that you grind up, put in a vaporizer, and administer that way. But there's also a huge other array. So pastilles. People might refer to them as gummies, or they look like essentially round trees, starburst or something, but are manufactured to a pharmaceutical grade and have contain those things. So, but they haven't gone through that process of going through the MHRA to demonstrate efficacy and safety for a specific indication.
I see. So then your role is basically to figure out if it fits the indication that the person's coming with an unlicensed product.
Yeah, exactly. So the way it works is if you are let's say a consultant neurologist and you're seeing someone with epilepsy, your first job is to decide, is medical cannabis right, yes or no? And then essentially how it works is that in the legislation is that what is produced must be manufactured to the specification on your prescription pad.
Okay.
So it's almost like you are making the order for it to be manufactured. Obviously, that's kind of a bit in reverse. These things are already manufactured. Otherwise, you're waiting months, if not years, for them to come through. But it's kind of almost like they call it special because it's almost like a special order. Like you put it on the prescription pad, and then it has to be manufactured to what you put on your little paper prescription pad that you then send off to the pharmacy.
Okay, fine. So that makes sense. So let's say, what's the most common way that someone is referred to you? So is it that someone will have a condition, go through the NHS, then they'll get to a consultant in the NHS, and then they say, oh, this person could do with like medicinal cannabis, or do people self-refer? Like, how does it work?
We really thought that was going to be the way that we were going to be operating, in that people would go to their consultant, their GP, and they would refer. Really, we do get some of that for sure, and that has increased over time. But by and large, most people self-refer to us. They've kind of got to a point in their medical treatment whereby they want to explore whether medical cannabis is right for them. And so I would say 90+% of people who apply to us is done through self-referral. That's not to say we don't get support from their GP and or specialist. So everyone is required to provide their summary of care records at a bare minimum, if not specialist letters, if not, particularly for those with complex psychiatric conditions, actually buy-in from their local community mental health team to say, yes, we support, we can't prescribe this through our means, but we support you being prescribed this via Curative Clinic.
Okay. Because it seems like as an outsider looking in, it seems as if there's greater standards for cannabis. Would you agree with that? Like meeting a safety level that it has to achieve?
I mean, yes and no. So it hasn't gone through that MHRA process that I talked about. So, so it's not licensed, and therefore, I can't come on here and say that medical cannabis is X% safe for X amount of the population.
Yeah.
You just haven't got that type of data. We do know from sort of more observational real world evidence that, largely it is well tolerated by a large proportion of the people that we see, but that's not true of everyone, and some people do suffer side effects from it. But that's like every medication.
Yeah. So we're not at a stage where we can say that cannabis more generally is safer than X drug. Like, do we have like a risk?
No, we can't directly compare. That's that. So we haven't. If you want to do that, you need to do a randomized controlled trial where let's take chronic pain, because opioids versus medical cannabis.
Exactly. Yeah.
What's the outcome? But because we're kind of comparing, I wouldn't say apples and oranges, maybe oranges and satsumas. In that we're sort of comparing like two observational data sets.
Yeah.
But when you're looking at observational studies, those people can be different.
I see. Yeah.
So when we're looking at a study looking at the outcomes of people with opioids and the study of people we can look at them both, and we can kind of summarize a little bit and try and mesh together in our heads what the overall thing is, but we can't say oh yes, this thing is definitely safer. This is definitely more efficacious, if that makes sense.
Yeah, that's so interesting because I feel like that's at least with younger people, that's kind of the pop culture understanding of cannabis, that it is like very innocuous. It's very safe, especially compared to like alcohol or like other drugs that you get prescribed from the doctor. But so it seems like we don't have the actual data to be able to definitively say this is the case.
Yeah, I would agree with the second part of that we don't know definitively. On a scale of harms, it's really difficult to say. I mean, it's currently a Schedule 2 medication, so there's lots of regulations about where it can be prescribed and how it can be prescribed. But in terms of its overall safety, it's difficult to compare against other things. But we know from the data that comes out of our clinic, for example, that the sort of around 1 in 5 people report adverse events from it. The majority of them are mild to moderate.
So did you say 1 in 5?
1 in 5.
An adverse event.
Yeah.
And how do you define that?
So we use clinical trials criteria in order to be able to define that. So we ask patients both during their consultations and then also through automated reminders to complete adverse events forms. And every adverse event then has to go through the yellow card warning system because it's an unlicensed medicine. So if someone sneezes on medical cannabis, that's maybe being a bit facetious.
Yeah.
But and anything that anyone reports as an adverse event, whether we know it to be treatment related or not, then gets sent off as a yellow card warning against the MHRA. So that's kind of coming back to that bit about this when you said maybe medical cannabis is safer than other things that we have increased reporting mechanisms because there's that kind of unknown. So there is that kind of safety that's brought in from that point of view.
Okay, fine. So what do you think are people's main reason for seeking medical cannabis then? Like, what do they think about it before they seek it?
I think there's a few. The most common one that we see, when I mentioned at the top, sort of around 1.4 million people are estimated to be using cannabis illicitly, like to kind of self-treat their health conditions. About 65% of people we see at Curative Clinic have previously tried cannabis in some formulation. And if you have tried something in an illicit setting and it has, has properties that you have found beneficial for whatever condition it may be, you then are more likely to then obviously go and seek a legitimate route into be able to managing your symptoms with medically, pharmaceutical grade cannabis. That's what I think. The other one is largely people kind of at their wits' end, because of that kind of process that I talked you through right at the very beginning, whereby people have to be able to demonstrate that they've tried a sufficient number of licensed therapies. The people that we see are typically those with some of the most complex chronic pain, anxiety, psychiatric conditions, neurological conditions, etc. And they are kind of the people who are like, I've tried everything. I just am at a loss as to what my next step is. I've done a little bit of my own research. I want to explore whether this is that's probably, it's a smaller bucket of people, but that certainly makes up a significant proportion of the people that we see as well.
Yes, I find it interesting that people have tried it like illicitly and then go for the medicinal route. You don't have to speak about necessarily the costings or whatever, but do you find that people like take into account, well, it costs this much if I get it from my dealer, it costs this much if I get it from a doctor? Like, is that a factor as all?
Yeah, I think by and large, it's difficult to really do like a robust analysis. But when we've tried to look at it, it looks like it's pretty much a wash between illicit and medical routes. You have additional costs up front with accessing medical cannabis because you're paying for clinician time, like to go to a clinic, and that has its own associated costs. But if you were to kind of like spread that out across a year, it looks like it's around about the same across both. But obviously, alongside chronic health conditions, that whether that's typically associated with a negative economic status, whether that be you can't work because of your chronic condition or whatever it may be, and so therefore sometimes that upfront cost can be, again, a little bit of a barrier. But so at Curaleaf Clinics, we have like an access scheme to reduce the cost of a clinic appointment with, essentially a doctor that practices on Harley Street to £50.
Oh wow.
And that's when they contribute to this data source that I mentioned, whereby we've collected data on almost 20,000 patients now, sort of assessing their outcomes across all those different conditions. So if they sign up to kind of take part in that registry, they get discounted clinic costs to £50 to hopefully make it that bit more accessible. I know that £50 to some people is a lot, but hopefully it's a hopefully a reasonable amount for what we see as being a premium service.
No, I mean that makes sense. The fact that you can't really get it anywhere and it's so like nascent in where it is as well. Obviously, like you can't necessarily speak about the research and the hard data, statistical analysis, and that kind of thing. But as someone, as a doctor, like we all prescribe opioids, we all prescribe like amitriptyline, gabapentin, these kinds of neuropathic painkillers. In your practice, have you seen any distinction in how the patient groups react to certain medications when compared to medicinal cannabis, or are we just not there yet?
I don't think we're there quite yet. Some of the interesting things that we have found, and this actually kind of generally follows across a number of different condition areas, is that we found people with fibromyalgia tend to be a little bit more sensitive to adverse events from medical cannabis.
Oh, interesting.
But that is kind of, unfortunately for people who suffer with fibromyalgia, kind of common across all medications they try.
Yeah.
Because it's a condition that sort of affects your sensitization to a number of things. So the most common thing that people think of is to touch and therefore pain. But commonly people with fibromyalgia have IBS or other sensitization syndromes whereby they are just inherently more sensitive to medications, unfortunately. Another interesting thing we found from a recent study is that women tend to be more likely to report adverse events, but also tend to be more likely to report that they have an improvement in their general health related quality of life, which is quite an interesting dichotomy.
Yeah.
But it does have some biological basis. So so estrogen tends to upregulate our cannabinoid receptors. So not a lot of people know that we have sort of a cannabinoid system within us where we have compounds that look like CBD and THC, mainly in our central nervous system, but also floating around our blood, and receptors that then respond to that. So estrogen tends to upregulate those, and that probably is a reason why they may be more sensitive to the adverse events if they do get adverse events, but also if they are going to have a positive effect, they're more likely to get them because they have more of these receptors in their brain because of the estrogen going in their body.
That is interesting.
It's like an interesting thing that we found quite recently, actually. So
So when like with the unlicensed category of cannabis, let's say you're prescribing it to a patient, you have someone with X condition, how are you making a decision of the formulation? Because is it just simplicity of use or patient preference, or is it that one is more effective in this condition?
It's a combination thing. Obviously, as with everything in medicine, it's shared decision making.
Of course. Nice Oski answer.
I haven't quite forgotten all my skills. But it's all shared decision making. But we do have like general guiding principles in terms of certainly what to start people on. So generally, broadly, we want to try and give people oils as much as possible rather than flour. And the reason for that is it's condition dependent, but the rationale is that oils tend to have a longer half-life and a lower peak. So for the most conditions that we see, they're chronic conditions, and therefore we want to aim for a steady level in the bloodstream over a period of time rather than these peaks and troughs. The sort of exceptions to that may be for someone who has maybe chronic pain, but then bouts of acute pain on top of that. So they need something that has a quicker release and therefore tails off more quickly because the acute bout of pain then subsides. So something like flower would be much more appropriate to that, because you vaporize it, the peak effect is within half an hour, and then the effects will be out of your system much quicker. Another good example of that may be people with insomnia, who specifically their problem is with getting to sleep. So you want a quick onset, but you want to, make sure that they have no hangover effect in the morning. So then again, flower might be preferable for that, because you have that quick onset in 30 minutes. When it's being prescribed for helping with sleep onset to help them get to sleep, and then after that, when they wake up in the morning, they have no after effect of the medication. They can just go about their day as they normally would.
Okay, that makes sense. Because I mean, from my very my very shallow understanding of how cannabis is metabolized, is it the case when you eat it, it becomes a different molecule? Does it through first pass in the liver?
Yeah.
So does that just inconsequential, or is that something that we've considered?
No, definitely considered. So, again, this is why the oils are prescribed to be taken like sublingually, so under the tongue, purposely for that point of view. So,
of course, yeah.
So then you bypass the first pass metabolism. The difficulty is, I don't know if you ever tried to keep like an oil or water under your tongue for 10 minutes. It's really difficult.
Is it?
So there's actually been some recent studies to suggest that when you look at the pharmacokinetics of people who take it sublingually and orally, actually there's not too much difference, because most people who take it sublingually end up swallowing earlier than they are attempting to.
Of course.
So there's a slight difference, but that generally it ends up being quite similar in real world practice. Obviously, in like a perfect study whereby someone can sit there and really keep something on their tongue for 10 minutes, it does look different.
Yeah.
And that's what we're aiming for.
Yeah.
But when it comes to kind of real life practice, it does end up that people end up unfortunately swallowing it. But that's like one of, we're starting to get more products coming to UK, like I mentioned, that are pastilles, where you're chewing it rather than having to keep it under your tongue. So again, that's something that's maybe slightly easier.
I see.
There are some limitations to it, in that it doesn't have as broad a range of CBD and THC contents as oils do, and so that's one limitation to their use. But certainly for people that find it really difficult to keep something under their tongue, it's a good substitute and gets what we're looking for there in terms of increased buccal or sublingual administration rather than oral, and then changing essentially what the underlying product is.
Yeah, of course. So is there anything that the oral like version, because you said they do the like gummies, the edibles kind of thing, is there anything particular that treats versus the smoked or lingual?
Yeah, so there are capsules, and the one like group of consultants who tend to use that more so than others tends to be the gastro consultants, so for inflammatory bowel disease, because what they are essentially looking for with that is more direct administration to the gut, rather than increase in like plasma concentration. But no, by and large, it tends to be either like vaporization for a quick onset, or sublingual for that kind of longer maintained effect.
Yeah, I see. And what do we know like about the actual risk factors and side effects and consequences about cannabis? Like, what can we actually say about that?
Yeah, I think in terms of the side effects, I think so the most common ones tend to be well, let's start off with what I said at the beginning, which was around 1 in 5 people in our study from the UK Medical Cannabis Registry report an adverse event whilst they're on medical cannabis. So that's the first sort of highlight.
Yeah.
Beyond that, what we see as the most common adverse events tend to be dry mouth, fatigue, concentration impairment, anxiety, which is interesting because we also see people for anxiety.
Yeah.
And that again kind of speaks to the complexity of the effects of the compounds within medical cannabis. So what we know from kind of my studies is that Whereas like most medications, you just kind of tend to see this like linear line going from bottom left-hand corner to top right-hand corner, whereby you give a small amount, you get not very much effect. You give a large amount, you get a large effect, and it kind of just follows in a nice linear pattern. With the cannabinoids, what you tend to find is this U-shaped pattern, whereby because our endogenous cannabinoid system acts as more of a regulator, so it sits on synapses to regulate the release of the neurotransmitter from that neuron. So whether it's a glutamatergic neuron, it releases glutamate. If it's a GABAergic neuron, it releases GABA. So, it's either going to be having an inhibitory effect, or it's going to be like having a promotory effect, depending on where it's acting in the neurological system at any time. So what we tend to see is this U-shaped curve, whereby there's like kind of an optimum amount, like right in the middle, and at either ends, you're going to like either have someone who is still anxious, or you're going to be like having an you're going to be generating anxiety in that person. So you're kind of like looking for like this real middle ground. And so that's why we see that in our population cohort. The other reason is that we don't make any distinction as to whether something is drug related or not. So we may get people who have anxiety who just say, I've got anxiety, and then we're recording it because it's the right thing to do. But it may be that it's just related to their underlying condition rather than it being a medication effect. But we've always taken the approach that we would rather over-report the adverse events in this medication type rather than seeking to hide behind anything.
I mean, it's still valuable as well, because you can compare it to the general population as well, and you can say, is it higher or lower, whatever. I imagine.
No, exactly. I think like in our headache and migraine cohort, for instance, like it's a very uncommon adverse event that's reported amongst the 20,000 people in the cannabis registry, but in that population, it's in the top 5.
Wow, so, I see.
So
okay.
So kind of take that with a bit of a pinch of salt. But certainly for those other ones, those are like the top 5, like across all conditions. They tend to be like really quite common. I think the question that I'm sure you may have got to, and people always ask me, so maybe I'll get to it.
Please.
Psychosis.
Oh yes, the classic.
So what we have tended to see in our populations is we have had instances of psychosis. They tend to be in people with quite complex mental health problems. And when talking with some of our psychiatrists, they think that the rate of psychosis that we're seeing is lower than they would expect within that population just generally. Obviously, this is like a highly selective cohort. We don't choose people who definitely have active psychosis or previous psychosis or schizophrenia or diagnosis of schizophrenia. So we're kind of not having those people who are already obviously predispositioned to having psychosis, but
family history as well, or is
that becomes a bit contentious. But we definitely see people with complex PTSD or severe depression, and we know that some people with those conditions may go on to develop psychosis as part of their disease course anyway. And then if we look at data from Ontario in Canada, they looked at sort of hospital admission rates as well as severe mental health problems in their medical cannabis population. Like the use of medical cannabis and prescribing medical cannabis is much different in North America than to how it is here. But again, they suggest that there is a lower than expected rate of severe mental health adverse events within their medical cannabis population. So I'm not discounting the observational data around illicit use of cannabis that then has led to psychosis. We definitely know that you can get cannabis-induced psychosis. That is definitely a thing. And high levels of THC consumption in individuals that are predisposed to psychosis can lead to psychosis or precipitate a first psychotic event in someone with schizophrenia. But when you're giving medical cannabis in a controlled environment to people that you're following up on a quarterly basis, and you're choosing the product that is the right fit for them, we don't see the levels of psychosis that you see in the observational studies from illicit use. And that that could also just come down to the fact that like we did some some recent analysis of illicit cannabis products with the Mandrake Group at Manchester Metropolitan University. And when you look at the THC content of all of those, like they're all kind of hitting 30% or above, whereas that's kind of like the top limit.
Yeah.
So, and the way that you consume like cannabis from a recreational point of view is completely different to how you would consume it from a medical point of view. You're going to consume high quantities in a in a short time frame rather than something that's pharmaceutically manufactured over a long time frame. And so but certainly it's not something that we see at anywhere near the levels that you see in these observational studies of illicit cannabis, for sure.
Yeah, and that does make sense. What is the difference between like us and North America, between how
and in terms of how medical cannabis is prescribed?
Yeah, or treated generally.
Yeah, so I mean, the United States is kind of its whole kettle of fish, because obviously it's illegal at a federal level.
Yeah,
but then most states either go for a medical first option and then recreational either, or never recreational, or both together.
Yeah.
So how it works in the United States, which I know a bit more about than Canada, is essentially, and it depends on state by state, but this largely fits most states, is you go and see a doctor, and rather than in our system whereby the doctor writes out a prescription for you, they will decide whether you are eligible for a medical cannabis card, and then you'll normally pay like the state a fee, a nominal fee, like $150 for that card. And then rather than like getting something prescribed, going to a pharmacy and getting it delivered to you or picking it up, you then go to what's called a bud tender.
And dispensaries.
Like a dispensary, yeah.
And
then this person will tell you what you should be taking for your medical condition, not a doctor. But like someone, they'll say, this is what you have anxiety, you have chronic pain, this is what you should be taking. So yeah, it's like, and also they have a real problem because of it being illegal at a federal level and around the scheduling of cannabis, that it means that they're still operating in a system where there's a lot of like illegal cannabis dispensaries, and it can be hard for like regular Joe or Jane public to then distinguish between what is a reputable regulated source or an illegal operation, essentially. There are laws coming into place in the United States potentially over the next year that are going to make that a bit better, but it's a very different system to what we have here in the UK.
Of course, and that makes sense. I mean, also it's because the system's different as well. Like for them, it's more of a wild west. If you have the money, you can get it basically with healthcare.
Yeah. The healthcare is completely different. But I guess they're kind of more used to there being like this kind of different provider model, whereas we're like, I have a GP, I have a local hospital. I see. These are the two places I go. Yeah. Whereas like in the United States, you're like, well, this is my my family doctor, and this is my gynecologist, and this is my this is where I go. This is my orthopedics. So it's a different world from a healthcare point of view generally, but definitely in terms of medical cannabis for sure.
Yeah, I mean, I think it kind of hits on why this is such a difficult subject to speak about, because you have medicinal cannabis, then you have recreational illicit cannabis, whatever you want to call it, and it's like they're intertwined and spoken about together, but it's like they're almost different issues, because one is like a scientific medical question, and then one is like a political philosophical question on a certain level, and then those overlap over like public health kind of things. But it almost seems strange to me that America went medicinal first and then recreational, because recreational is just a question of, do we want a society where people are allowed to smoke weed? Like, what are the ethics of drug legalization, all that stuff? But then medicinal seems like okay, what is the data on this? What is the research saying? What is medicine saying? Like, but yeah, it's just always fascinated me how it went that way. And even if, I mean, the UK does decide to legalize it recreationally, that seems to be what we're doing as well.
Yeah, I mean, I think the rhetoric out of both Conservative and Labour camps is like quite anti-drug at the moment.
Yeah.
Because they both want to seem tough on crime.
Yeah.
But I think in terms of my views around sort of recreational cannabis, I mean, it's a difficult one, and I don't think any country has quite got it 100%
No.
spot on, whether that is, full prohibition to, some of the most liberal countries out there. And I think everyone is kind of looking to each other to be,
Yeah.
because obviously we know that Germany is legalizing recreational cannabis in the coming years, and there's kind of like a stepwise process. And I think probably what's going to happen in Europe is everyone's just going to look to Germany and see what happens there, and then see if that works or not, and then make a decision about what they do based off that. But what I really want to see from my point of view is I think that everyone's goal should be to drive forward the evidence on medical cannabis so that we can get to a stage whereby, if it's appropriate, like if the evidence says that this is what should happen, is that you can go to a GP or your specialist and it'll be prescribed in an NHS setting.
Yeah.
Like, because what kind of happens if you push the recreational too much but don't invest in the medical cannabis sector, what you'll end up with is people who are kind of really experienced with accessing illicit cannabis currently for their healthcare conditions. They will go and use that, and it'll kind of service their needs. But for people who have whatever condition, it would ended up being licensed for, let's say, they would kind of be blocked out of the system if we don't push to get to a point where we have more licensed medical cannabis products for more conditions that are then available in NHS. Because even if you do make it available recreationally, there will be a subset of people who will be accessing that for health reasons, and it will suit them very well. But it will leave a huge spectrum of people who would otherwise want to access it, who can't if you don't, drive forward the medical knowledge on, pharmaceutical grade medical cannabis, at least alongside, but preferably before then.
Okay. What do you feel like is like the biggest barrier to us getting to like the ideal situation with medicinal cannabis?
There's a number of barriers. The difficulty is we're kind of talking about all these different products, and then so the cannabis plant contains what's thought to be in excess of 600 active pharmaceutical ingredients. The two biggest being CBD and THC. That's kind of what most people talk about.
Yeah.
But there are 142 other compounds that look like CBD and THC. So they're called like minor cannabinoids. And then you've got sort of 400 plus terpenes and flavonoids. And they all vary within a plant depending on what the strain of the plant is. So like what seed it's grown from, and then the conditions you grow it in. So even if you and I took the same seed, we went to and we grew it in two different greenhouses, it would have slightly different, end compounds.
Yeah,
on
of
the
course,
flower.
yeah.
And so think about if you're doing a clinical trial for, you're a cardiologist, you want to do a clinical trial for ticagrelor.
Yeah.
Right?
Yeah.
You just have ticagrelor.
Yeah.
Ticagrelor, X milligrams, same dose, blah, blah. You're trying to consider taking a kind of natural product which can vary and sort of generate and get to a place. And that's why the licensed products that I mentioned right at the top of the show, they're all kind of isolates. So it's either CBD only or CBD and THC or THC only. Whereas all of these other products, it's so difficult to firstly choose which one you're going to invest in down the line, because you don't know whether that's going to be the best option for you. You could choose an oil with this amount of CBD, this amount of THC, this amount of all those other compounds, but actually there could be another one that is much better suited. And then you take that forward, you spend millions of pounds in a clinical trial, and maybe it doesn't work.
Yeah,
and you say that, okay, that doesn't work. And then this is kind of what it has happened with medical cannabis, is then you write off all medical cannabis. You say medical cannabis doesn't work. We have a trial that says this doesn't work. But what happened if you were to change the CBD THC dose? What would happen if instead of you using an oil in this, you used a flower? What happens if you dosed it at, so that's kind of what we've been trying to do between Imperial and Curative Clinic is kind of dovetail that a little bit. So at Imperial, we're taking like preclinical science and looking in the labs, particularly like one of my colleagues looking at pain and all these different compounds and seeing like what is the optimum dose if you take them in isolation, what's the optimum dose if you put them together, and what's their effect on pain transmission. And then like kind of at the Curative Clinic level, what we're doing is we're taking our registry data and looking at the outcomes and trying to see on a kind of per product basis what are the products which are having the most meaningful effects for patients. And if we can try and marry that up somehow, maybe that can help us identify an optimum candidate to take forward for a clinical trial, and and de-risk it somewhat for whoever ends up funding it, whether it's government, charity, pharmaceutical industry, whoever it may be. It helps to give them some confidence rather than just going, here's X million. Let's see how it goes.
Do you feel, is there any like stigma against like pharmaceutical or government funding medical cannabis trials, or is it like, have we moved forward?
The government says there isn't. So when the law changed in 2018, I think everyone recognised there wasn't enough high quality randomised controlled trial data on this, and so the government said, we're going to have a special pot of money at NIHR to fund like cannabis related research. That was like put out. So the other thing that came with rescheduling for patient use, obviously that changed the scheduling for use in research as well. But the scheduling is only once it's been written by a doctor. So technically, medical cannabis before you've written the prescription, like when it gets shipped into the country, is still technically a schedule 1. And then when you write the prescription and it's manufactured into the little like bag it comes in, or the bottle, then it becomes schedule 2. So there's still a lot of barriers in terms of conducting research. And the problems that come with that is there just weren't very many medical cannabis research groups set up around the country to research like kind of the positives. There's lots of people who are set up around sort of substance use and looking at illicit cannabis, but not many who were set up appropriately to then be able to study the positive benefits. So that closed with no one being successful for funding from it. But then that funding has kind of been lost into the ether of all other funding. And also that all happened within the context, obviously, of COVID. And so it was a difficult time to really start up research anyway, because everyone else was kind of had their focus diverted onto COVID related stuff, or it was difficult to get into labs and things like that. So I looked on the NHR website yesterday. And there has been one study funded looking at kind of the positive benefits of medical cannabis, but it's to look at CBD as a treatment for cannabis use disorder. So it's kind of like in the context of but otherwise NIHR has not funded any studies to look at the positive benefits of medical cannabis. And you may say their argument may very well be there just hasn't been a good enough application come forward to us in order to be able to fund it. So that could be the reason why, but it could also be stigma. It's hard to say. We know that at a patient level, the stigma is changing and is getting better. People feel like they can talk to their friends and family about it. And this is from like a study that we did with patients from Curative Clinic. But interestingly, the people that they find most difficult to talk about is their healthcare professionals and like kind of like authority figures in their lives, whoever that may be. And so we still have a lot of work to do around stigma, even though I do think it is improving.
And what in with like CBD as well, because that's something that's sold at like wellness places for treating X, Y, and Z. People vape it now. Is like, what is there anything to that as a wellness thing?
So, no is the quite easy answer. So, so CBD that you find like in a health food shop or like in food and drink, they've kind of like gone through like a bit of a difficult time in terms of like their governance. There was some studies showing that essentially in like 2019, 2020, if you went to somewhere and you bought something off the shelf, you likely wouldn't be getting what it says it has on there. And some of them even contained higher than legislated amounts of THC. So like potential for, potentially intoxication, but probably more likely, if you were to, God forbid, be in a car accident, someone tested your blood levels, you might come up above the limit, but you're not prescribed it, so you've got no statutory defence, things like that. So
yeah, of course, yeah.
So there's been a big crackdown, and so they're now governed by novel food regulations. And so that has helped in order to be able to improve the consistency of them. But it's still not manufactured to a pharmaceutical standard. So nobody has ever looked at taking, this product which can have a much broader spectrum of CBD in it compared to, a pharmaceutical grade CBD product. So nobody has looked at these CBD wellness oils where you can't really say with as much certainty what is in them as something that's produced to a pharmaceutical level within the context of any clinical study. And so like the benefits that these companies claim are off the back of either medical studies or preclinical studies, but no one's looked at, if you have X amount of CBD plus or minus whatever large range that they're allowed to have in there.
Yeah, I see.
Like what is the end clinical effect? But actually it's kind of gone even a step further. So recently the Food Standards Agency has reduced the amount of CBD that can be contained within these products to a maximum dose of 10 milligrams.
Okay.
And 10 milligrams is tiny.
Is it?
Like, yeah, it's not going to really, it's like, there's no studies that have looked at sort of a minimum of 10 milligrams.
Really? What's the like normal dosage?
Much higher. Like it all depends. Like some people might have, like in terms of the context of medical cannabis, some people might have no CBD, but obviously they'll have THC as part of their treatment. But if you're looking at studies of epilepsy, for example, where we have like, that probably has the most randomized controlled trial data on isolated CBD, you're talking somewhere in the region of 10 to 20 milligrams per kilogram.
Oh, wow.
Per day.
Okay.
So, medical school, average 70 kilogram male is, it's 140 milligrams.
Yeah.
You're kind of looking at give or take. So, I don't think anyone, you'd find many doctors advocating for its for sort of high street CBD oils or anything like that anytime soon.
Oh wow, because I've noticed it's become like a real thing. Like there's drinks with it in. There's like loads of like gummy things you can buy.
Yeah, and I think it's really difficult for consumers to kind of make that distinction. I think there's a lot of erroneous reporting that we see around, like even like what we do in terms of medical cannabis. People might report that as CBD oil, and so it's really difficult if you're just a lay consumer, you have maybe a passing interest in science, to really, I don't think many doctors click on a BBC News article and then go to the primary study.
No, true.
And so if it's being presented to you as like, the scientists from Harvard did this study using CBD oil, and then you just be like, oh, CBD oil.
Yeah.
But actually, it's not CBD oil. They've taken like a pharmaceutical grade medical cannabis product.
Yeah.
So it's I empathize with consumers. It's really difficult to navigate that stuff. But yeah, no, I certainly won't be advocating for a CBD cappuccino anytime soon.
I've actually seen that before. That's like a big thing, especially in the States as well. Like people tend to love that. For some reason, the mixture of coffee and CBD, it seems like you have the energy of coffee and then the calming after
Yeah, yeah,
effects
yeah.
of CBD.
Yeah.
Yeah, like there was a place in Bristol where I went to med school that like their whole gimmick was they put CBD into their drinks, but no, they went like bankrupt, I think, because no one really wanted it because it didn't taste very nice. But yeah, so what, like with the patients that you see, like that like come in every day, do you feel like there's a certain type of person, like a caricature patient that you have, or do you really get like all sorts of people?
We get like a really broad spectrum. We ha- we have some nonagenarians. Nonagenarians, did I say that right? 90-year-old.
Nonagenarians.
Nonagenarians.
Wow.
So some like 90-year-old patients.
Yeah.
We haven't quite got a centarian yet, but
You will. Soon.
probably will do it at some point.
Yeah.
Right the way down to 18-year-olds. So we see that broad spectrum. Generally, our population skews a little bit more male and a little bit younger than you might expect.
Yeah.
Of when you think about the conditions that we see, but that probably is representative of just kind of the shifting the underlying attitudes towards cannabis amongst those populations as being less clouded by some of the stigma of years gone by, and probably just like more open to considering medical cannabis as whether it's right for them versus not to then stigmatize older people, but they generally have different views as a whole compared to younger people around even cannabis that's used in this medical setting.
I see. And is there any like misconception that like you find in patients or in people in general that you, like that personally annoys you or that you find people tend to have?
Nothing that annoys me. I'm not that kind of person. But
that's good.
I think probably the biggest misconception that people have is that you're going to smoke it.
Oh, okay.
So, two things. We would never advocate for anyone smoking a dried flower prescription because, for health reasons, it's produced. It's not like cigarettes in that there are going to be other additive things in there because it's produced to a pharmaceutical standard. But if you ignite anything and you smoke it, you're going to create carbon monoxide and you're going to create carcinogens. And that goes for anything that you basically were to burn and then inhale.
Yeah.
And so we would never advocate it for it on health grounds. And there are actually medically approved vaporizers in the UK, so we recommend those people use. But in addition to that, it's illegal.
Yeah.
So if you are prescribed medical cannabis and it is your prescription, but then you choose to smoke it rather than vaporize it, that is technically illegal in the eyes of the law.
Really?
Yeah.
Wow.
So that probably is like the biggest misconception is people think that they think, oh, it can't be like a medical thing because you smoke it.
Yeah.
But no, definitely don't. We advocate against it on for health and legal reasons that you shouldn't do that.
Is there like a reasoning for that law by making it legal for smoke? Is it?
I don't know. It's just when the Home Office released the like change in like the scheduling laws in order to be able to allow medical cannabis to be prescribed, it was written like quite explicitly. It's like a line on its own.
Yeah.
The reason why I think it was probably in there, it may be that someone has decided actually on health grounds it shouldn't be.
Yeah.
And if that is the case, I give whoever decided that a lot of credit.
Yeah.
But I think that it's probably more of a policing thing, whereby it's it would be then easier to police if you see someone smoking cannabis. You then don't have to like make a distinction between them. I reckon that's probably maybe I'm just more cynical.
Yeah.
I think that's probably the reason why. But if someone has done it because of health reasons, then then good on them.
Yeah. So like, how many people are actually using medicinal cannabis? Like, do we have a idea?
So the last figure, and this is like kind of a year old, and is really like involves a lot of estimation, was around 35,000.
Oh wow.
I believe it's probably more than that. Certainly, by like this is early 2024, we definitely have more medical cannabis patients than 35,000. I'm sure of that. How many there is, it's really difficult to tell. The NHS Business Services Authority, BSA, are meant to kind of collect that data from those specialist pharmacies, but it's quite patchy. No one, they have data around how many prescriptions are fulfilled, but not the number of patients that it goes to. So, because you collect like the number of prescriptions over a year, it's really difficult to tell how many people that's ended up going to, because some people may stop taking it, start taking it at different points. So it's really difficult to say directly from that data. But yeah, no, I would estimate it to be more than 35,000 now, for sure.
35,000. I mean, that's quite a lot. Like, is it because also now? I mean, generally, I feel like we're going through like a big change in how like socially we see these kinds of substances, but also just in medicine. Because I mean, I know because when I was in med school in like my 3rd or 4th year, I don't know if you know David Nutt, like Ben Sessa, like they were like, they're quite involved in Bristol Uni specifically, and yeah, we would have lectures all the time about like the benefits and like the research of like psilocybin and those kinds of things. And it feels like psychiatry is kind of leading the way on that generally. But so it's good to hear that there seems to be other areas of medicine where this kind of thing is being considered. Like, do you come from the same camp as those people, or is it like with medicinal cannabis, or is that a different area, if that makes sense?
Professor Nutt is certainly very heavily involved in medical cannabis as well as psychedelics. I probably come from a slightly different position. I'm closer to Professor Nutt than probably a lot of people. He's probably a bit more evangelical about it than I am.
He talks about it more, or in that he believes in it more, if you know what I mean. Like he thinks it's more of a miracle than you.
Yeah.
Okay.
Yeah, I think that and he's done some fantastic things to improve access to medical cannabis in the UK and to drive forward kind of knowledge and research. But yeah, I think that he is just a bit more evangelical about its effects than I am. And we are quite close in how we see it, but he's just a bit further one way than I am. But yeah, I think there is a kind of like growing change towards the perception of medical cannabis, but I think the real shift change is at the moment you're kind of maybe getting 1 to 2% around the peripheries of changing people's perceptions. Maybe people are coming into contact with patients who are using medical cannabis, or people are looking more at the primary research themselves. There's probably, I mean, that's great that you had that education like at Bristol. I went to Imperial where Professor Nutt works, and I had 2 lectures on cannabis the entire time, both of them as a drug of harm and abuse. So, it's difficult because there's only so much space in the medical curriculum. Blah blah blah.
Yeah.
It's hard to fit in something that is an unlicensed medicine. You can't prescribe it as an F1.
No.
I can't prescribe it.
Yeah.
You have to be a consultant level. So the argument would be,
can GPs prescribe it?
GPs can prescribe it under shared care, so it has to be initiated by a consultant.
Fine.
The earliest you could technically prescribe it would be 6 years out of medical school under shared care as a GP.
Jeez, okay.
So, I understand the rationale of maybe it doesn't make up the entire curriculum.
Yeah.
But they could at least have one lecture that is kind of neutral.
Yeah, at least. I mean, and also as well, like, is it like how many people will use like methotrexate, for example, or like really niche like rheumatological drugs, but we seem to like focus on those like quite a lot. I feel like I think it also is just a sign of the changing times. Like I think we will eventually get to that point where it is at least seen from a neutral perspective.
Yeah, but I think it's kind of all comes back to what I was saying before, is like the goal of everyone should be to like drive the evidence towards where this becomes a licensed medicine, if that's what the evidence says. Because if this does become a licensed medicine, you immediately improve access to people who want to be able to access it, and indeed those people that never even thought about it, but then it automatically becomes like the fourth line treatment for X condition. But then also then it creates like this kind of groundswell for more education, because if you can prescribe it, then postgraduate colleges are going to invest in educating on it,
Yeah, of course.
because it then maybe becomes part of a postgraduate curriculum, it becomes part of an undergraduate curriculum, like all these things. Like if you can drive forward the research to kind of get to that point, you then have all these and then it will change public perception and stigma, because you will go down to your GP and you'll say, oh, I had this problem and my GP recommended me medical cannabis. I didn't like, if it comes from your GP rather than you having to go to I'm glad that we exist as a clinic to serve those people who want to be able to access medical cannabis, but if we can get to a point whereby it is something you can access on the NHS, that would be that's certainly the goal that I want to work towards. If not the rest of my career, as for certainly the next sort of 5-10 years.
Yeah, I mean, hopefully it does definitely come true. Because I mean, just thinking about things like morphine, opioids, like it seems like we do accept a certain level of risk with medications, and with especially medications like that. Is there do we know about the effect of cannabis in a non-medical setting, like in someone who's not got a specific condition? So in the same way we know like alcohol causes vernix encephalopathy, or steroids cause Cushing's or something. Do you know what I mean?
No, I do. So so I guess we've talked a little bit about like psychosis beforehand. So like people who are predispositioned can get cannabis-induced psychosis from like heavy cannabis use. The other one is you can get like a cyclical vomiting syndrome. So the typical symptoms of that are kind of, as it says, like heavy amounts of vomiting.
Yeah.
And interestingly, the thing that calms it is typically people report taking hot showers or hot baths, and that tends to relieve it. And that's actually working via the TRPV1 receptors, causing like that heat sensation on your abdomen, and then that relieves like the vomiting. But the only way that those people can really stop that is via abstinence from cannabis. There's that's the treatment for that essentially. Again, interestingly, in terms of patients that we've seen at Curaleaf Clinic, we have had one confirmed case, and a couple of maybes. It was that, maybe it wasn't, but we've been cautious and said we shouldn't continue. But we don't tend to see it as much in these medical populations, whatever the reason may be, whether it's the way in which we're prescribing, the way in which we oversee them, the kind of what they're being prescribed compared to what they're what someone would take illicitly or in a recreational setting. But yeah, again, in medical settings, we just don't tend to see it as much.
Yeah. And I think you mentioned last time we spoke, do you actually review patients when they come in, or is it like an online thing?
So this is like one of the things of COVID. We originally were planning to have all these clinics around the UK.
Yeah.
We do have one in London. We have one in Scotland, and then we were like, we're going to set up all these clinics at all these different cities: Liverpool, Brighton, Southampton, and then we got our CQC registration in late 2019.
Yeah.
And then in March 2020, it became very obvious that we weren't going to be seeing many people face to face for the foreseeable future. And then we transitioned to telemedicine and haven't really looked back. But it's actually worked really well.
Really?
And if you kind of think about, so for two reasons. The first is these people are kind of at the end of their treatment pathways. So they've kind of already had secondary and or tertiary level care, plus or minus, less relevant for psychiatry, but for chronic pain, they've had surgical input, scans, whatever it may be, if appropriate for their condition. And therefore there isn't as much benefit for someone laying hands on them to to then decide whether or not they should have this one specific medication. So it works really, and then therefore we can have more like geographic locations. Like we see people in the Channel Islands, Isle of Man,
Oh wow.
like deep north Scotland, Northern Ireland. You know, even if we were to set up clinics in all these different like cities around the country, there would still be people who are like geographically isolated from being able to access some of those, because you know, there's no way we would be able to be, you know, in the Shetland Islands,
Yeah, of course.
for example. So it really works out well from that point of view. But secondly, like when I mentioned at the top that each patient needs to be reviewed by a specialist in their condition, that again makes it really much more beneficial to kind of have this like location agnostic point of view, in that you can be in North Scotland and see a pain specialist who lives and works in London, and you don't have to recruit someone who lives up there, but they also have to go through an MDT process. And if you were to have like all these different sites around the UK, you would have to have like multiple doctors in each of those sites. It would be, you'd have to overcome a huge number of hurdles in order to be able to have a clinic in every city that you wanted to. So yeah, by having this system, we actually have multidisciplinary teams every day of the week, and they come together from all different parts of the country, who like whoever's available on a Monday, Tuesday, Wednesday, Thursday, Friday, and then they can discuss their patients from that week, rather than, you know, having to, because even if, you know, we had a clinic location in Brighton, maybe the pain specialist is free on a Monday, the psychiatrist is free on the Wednesday, Thursday, the neurologist is on the Friday, and you never get them together for an MDT, and therefore you can't really like treat those patients. So it's actually you know, been a bit of a blessing in disguise in some ways. You know, and we're grateful for the CQC, you know, being so facilitating in us moving towards a telemedicine model, when that wasn't really ever going to be you know, our intention initially.
And in terms of like your research, like is there anything in particular that you're working on now, or like you're looking at like a specific question?
So I think our key questions, now that we've kind of looked at a number of different conditions and kind of said, you know, at 12 months, this is the outcomes that you can expect if you take 1,000 patients with chronic pain, and you know, this is the number of people who report a clinically significant effect. Our next kind of step really is to do some of the interesting work, is to try and identify who is most likely to have a positive effect, who is most likely to have an adverse event. So one of the studies I mentioned before looked at, demonstrated that women are more likely to have a positive effect, and also more likely to report an adverse event. That's kind of more of the studies we want to try and do, is kind of determine who should we be, because at the moment we're kind of at a place whereby, and we're moving more, we have like a legal framework whereby you are eligible for medical cannabis, and we are more and more from this research being able to do, you're a suitable candidate for medical cannabis. You know, from our research we can like kind of look at some of like your background characteristics and say, actually you are more likely to be a responder. And then the next kind of step with that is to kind of say, these are the like therapeutics that are most likely to be beneficial for you. Like, you know, it'd be like years and years to get to a point whereby we say, you know, this specific I don't think we dealt with any medication yet. But you know, we can try and just kind of guide people more along the right ways in terms of who's a suitable candidate, what's the most suitable medication for them, and then also kind of help feed that back into our preclinical work, and kind of say, let's start to evaluate those medications in the lab and see like how they work in the lab, and then can we actually develop medications, like, you know, provide information to manufacturers of medications to say, these are the most interesting candidates to make available to patients that currently aren't available, because, you know, this kind of group works, but maybe you should manufacture something like this to take forward. So those are the kind of things that we're trying to look at.
Because I mean, it might be my ignorance on like research and medications and stuff like that. But did we do that for like oxycodone or for like morphine? Do you know what I mean? Because because I'm working in ED at the moment, and it just seems like we just think this person's in pain, give them oxycodone, give them morphine, whatever. But like I guess maybe it's because of the like you say, there's so many compounds in cannabis that we have to really like isolate. Does this work for that? Does this work for that? What formulation works for that? But is there more of a specificity in the world of cannabis, or are all drugs in this way treated the same?
I think maybe oxycodone is a bit of an exception because that's kind of a newer opioid.
Yeah.
But certainly kind of our long-standing medications, paracetamol, aspirin, etc. Maybe aspirin is a bit different because it has gone through randomized controlled trials subsequent to that in terms of looking at it for stroke prevention, heart attacks, etc. But its use as a non-steroidal anti-inflammatory drug, for example, it's like one of those things we just like. It works. We know it affects like COX enzymes. And we know we know that this is kind of the dose to give. But if you ask someone to dig out a randomized controlled trial that says that paracetamol is the best thing to give,
that's
as like a first. But like people be like, we don't have that. Like we just are kind of like. So I think it's just the increased rigor that we come to expect. Though as medical science moves forward, we're just in kind of a slightly weirder place with medical cannabis in that we kind of have data from all these different sources, like kind of people who've been self-medicating illicitly.
Yeah, of course.
Kind of some, like its medical use back in the 1800s before its prohibition. Research from other parts of the world that we're kind of like all putting together in this like mismatch, rather than like your really traditional like, what is your next biological therapy for IBD? Okay, we have this preclinical candidate. Okay, we're going to do a phase 1 trial. That's promising. Phase 2, phase 3, phase 4. We're kind of like, it's available for patients. We're doing observational research. We're doing the preclinical stuff. We're kind of missing that meat in the middle. That we really need to see to push things forward.
And do we look at like the US, or do we say because their system is so different that we?
I think we definitely do look at the US, but I think now we're kind of at a stage whereby it's just kind of randomized controlled trial data or sort of really high quality observational data. It's really difficult in the US because of the fragmentation of their healthcare system. And the fact that you're not controlling what someone then goes on to purchase on a medical because like that is not determined via prescription. Whereas like the data that we collect through Curative Clinic, we know exactly what someone is prescribed, and therefore we can see what their outcomes are compared to that. Whereas in the US, it's kind of a bit like medical cannabis patient, this is their outcome. So it's a bit, it's much more challenging to and much less robust in terms of what you can look at from that kind of data in the US. So
Has there been anything in the research that surprised you that you didn't think would necessarily be the case when you first got in?
That's a good question.
Take your time.
I think not necessarily surprised me because I knew this somewhat when I was kind of coming into it, but it's kind of this ubiquity of all these different conditions that I'm looking at, and it's what keeps things really interesting for me, because I might be working on a research project on anxiety, arthritis, epilepsy, and the fact that it's like kind of touching all of these different points. I think that kind of comes back to the fact that the endocannabinoid system is kind of like a regulatory thing. It kind of, can either promote inhibitory signals or promote excitatory signals in the brain, and it kind of depends on what levels you're kind of delivering where, and kind of we don't know exactly, how that ends up as being like that exact end outcome. But I think that, it's not necessarily surprising, but it's definitely the most interesting thing about looking at medical cannabis for sure.
And where did the things that you look at, where does that come from? Like the arthritis and
like the indications.
Yeah, the indications, because it's like quite a colloquial thing that we all know. Like people take it for inflammation or anxiety or whatever. But where do you get that from in research specifically?
Yeah,
like
so
then-
my data all comes from the UK Medical Cannabis Registry, but that obviously is then dictated by what doctors are prescribing for patients.
I see,
So
yeah.
kind of taking that one step further back, it's kind of those conditions whereby like the doctors that work at the clinic have decided there is sufficient evidence to trial it in someone who has not been able to gain sufficient benefit from like first line treatment options. So you know, for example, in what's a good example? So, if like chronic pain, for
Yeah.
instance, there's like kind of a mismatch of different consensus opinions like across the sphere. Some people think that it does have an effect. Some people think it doesn't have an effect on chronic pain. If you were to like take like a systematic review and meta-analysis across all these different things, but what we do know from preclinical research is it affects pain transmission from the site of pain. It affects it in the in like the dorsal root ganglion, so from the peripheral nervous system. It affects central sensitization and also descending inhibitory pathways, and it also affects how your brain interprets and emotionally kind of deals with pain. So we know that from preclinical evidence. There's lots of observational data to suggest that in some people it works, in some people it doesn't work. And then there's randomized controlled trial data, which, you know, some people, depends on how you want to kind of cut the data. So there's an article in the BMJ which suggests that medical cannabis is associated with a 10% increased risk of having a clinically significant benefit in chronic pain. There's a systematic review from the International Association of the Study of Pain, which comes to a conclusion that it's kind of equivocal. There's nothing to support it or against it. And I think they both are looking at exactly the same subject. They just apply different inclusion criteria to their search.
I see.
And then therefore come up with like slightly different answers.
Yeah.
But, you know, there's certainly enough evidence there for you to be as a doctor and say, well, this person with chronic pain has tried all these different options. Nothing has worked sufficiently for them. There's enough evidence there for this to be like a last line option to treat them for. So that's an example of how we like kind of get to the evidence around chronic pain, but it's kind of applying that thread to all the conditions that we see. So, you know, nothing has that gold standard like 10,000 randomized controlled trial. Otherwise, we'd have those licensed therapies I was talking about.
Of course.
But it has, you know, sufficient evidence for the doctors to think, I'm going to try it in this patient cohort based on the level of evidence that is currently available as a last line therapy.
Yeah, thank you. So is there, like, I think we have a couple minutes left. Is there anything you want to say to patients who could potentially be considered for medicinal cannabis, or to clinicians who like don't know anything about it, like just as a way to be like, this is a good summary bullet point for those people?
Yeah, I would suggest for patients and doctors to put aside any preconceived notions that they may have, good or bad, and just do your own research. If you don't know where to start, like we've generated some, both a patient and a clinician education site. For clinicians, it's CBD accredited, so you will get CBD points for it. So if you go to like cureleafeducation.com, there's a patient sort of education you can go through. You can do quizzes. You can like learn about what is medical cannabis. Clinicians, you can do the same in a slightly different format, but you know, for healthcare professionals. But also like don't just rely on me and that. Like go and do your own research. Like kind of put aside that stigma, do your own research, and come to a conclusion yourself. 'Cause it's, and I know as clinicians, like we're all time poor, and you know the last thing you want to do is go away and study something that you're not going to be tested on. No one's really going to no patient's going to ask you about, and if they do, you can kind of you know, you can get away with fobbing them off essentially, because it's something you can't even prescribe.
Exactly.
So but I would encourage them to do to kind of consider doing their own research about it and just like forming their own opinion, even if you can't prescribe it in your NHS practice. You know, just make sure that you feel confident in what the current research is about it, so that if someone does approach you, you're not fobbing them off. You can give them a reasoned, rational answer, and that can include that you can't prescribe it, but you can, you know, help support, you know, a patient who has a legitimate health problem.
Right. Thank you very much. That was very well said. And again, thank you for coming on. That was honestly so interesting. I think people definitely got a lot out of that. And we'll definitely have you back again. I think that was so interesting. There's so many more questions I want to ask, but we were like running out of time. Yeah, thank you again, Simon, and I'll see you next time. Okay.
Cool. Thanks, Ricky.
Bye bye, everyone. See ya.